Welcome to the first version, and obviously this is the beginning. Is no way it's going to be the last. Obviously, it's the first joint collaborative effort of the Department of Oncology and Critical Care Medicine, where we wish to bring on the subjects which are pertinent to both the departments, because we both need each other in every aspect of our care. And to welcome, I would invite Professor Dr. Rahul Pandit, who is the chair of Department of Critical Care, and ask him to invite Dr. Sevanti to initiate the process. Pandit sir.
Thank you, Dr. Arindam. Thank you very, very much for the initiative. I must say this initiatives do come from Dr. Arindam's armamentarium of involving and having a collaborative effort with all the departments of the hospital. And it does give a lot of impetus to our students who obviously need 360 degrees understanding of critical care and the various specialties. And to start off with, we have none other than very, very talented, very, very hardworking, and a very close friend of mine. And I've known the family for last almost 7, 8 years now, Dr. Sevanti Liman. Dr. Sevanti is the director of medical oncology and precision oncology in Sir H.N. Reliance Hospital. And she's also into the translational research, which sort of is the next niche area in which you can actually have a cancer research based, which could be receptor based, which could be precision based, where you could actually target a particular gene or a particular area of a receptor and could bring out a magical change in the progression of the cancer. So she's worked very, very long time in the US, and then to serve her motherland, she's come back. And she's been in India for some time now, Mumbai now for almost 7, 8 years that I know of. And we would be very, very keen to hear from her about medical oncology, precision oncology, how it sort of translates into ICU and where ICU can step in. So without wasting any time, Dr. Limay, all yours. Thank you.
Thank you. Thank you. Thank you so much. Thank you, Dr. Arindam. Thank you, Dr. Rahul. For this warm welcome, very warm welcome. And like you said, I feel like a family. I've always felt like a family. So I trouble you all a lot. And of course, I lean on you big time for all the help which you have so graciously provided. Each one of you, both of you that are here and your teams, so really, truly highly obliged, and as updated as nearby as last night, supported by ICU, now this time in a personal cause. Really, really grateful for all the support and on all the love. So starting, I'm speaking on immunotherapeutic drugs and side effects. But before I start that, a very quick word on precision oncology. So as we know, precision oncology is essentially, I say it all the time, it's an orientation. It's not a new test. It's not a new therapy. It's an orientation, because therapies in oncology are already established. When we orient ourselves to a biomarker in a patient and we try to do more informed application of a treatment, we call it precision. Precision is ubiquitous. It's everywhere. Precision is in ICU. Precision is the way we treat our patients. So I always say this, there is no other way to treat a patient rather than precision. It is a cliche in oncology. Why? Because for a time immemorial, oncology applications were actually very, very generic. They have been per disease system. So if lung cancer, you would give this chemotherapy. If colorectal cancer, you would give that chemotherapy. And standard of care options have evolved based on that. But as we developed, as the science developed, and it is an ongoing process still, by no means have we reached anywhere to really be too proud. But we have gotten somewhere. We have made some strides, and those strides are very, very focused. They are based on biomarker-based approach. And that has become the new age way of approaching a patient. because it delivers higher outcomes. And that's what we are all looking for, especially when a disease is directly connected with death and dying. And who would understand this better than the ICU team? So today we are going to talk about immunotherapeutic drugs. So immunotherapy is considered one pivotal modality of cancer therapeutics that has happened in the last decade and a half. I would say one of the first trials with a blockbuster drug called Keytruda or pembrolizumab was happening in Dana-Farber when I was a junior faculty in the year 2009. And the trial was called Keynote 001, and I was a co-investigator on that trial. Prior to that, the work with immunotherapy has been done in skin cancer called melanoma. And the story in precision actually informs this application, because these are certain receptors that are on the surface of the cancer cell that repulse the T cell. And if you block that receptor, the T cell is able to come near the tumor cell and eat it up. So when this process happens and the T cell eats up the tumor cell, cancer slowly is supposed to disappear with the help of immunotherapy in certain malignancies. But as a result, also what happens, there could be a higher immune activation, and that could lead to side effects from immunotherapy. So with that, I will quickly go to my presentation, and I'm going to try to keep it very, very short and precise, so that then we can do question and answers. So essentially, when we talk about therapeutic options, broadly speaking, we've always known surgery and radiotherapy. They have been the gatekeepers in oncology treatment. And then time immemorial, we have also known chemotherapy. Targeted therapy came somewhere around the late 1990s, early 2000s. And then came immunotherapy, where, as I just described, it's about empowering body's immune system to fight cancer. And here you have the tumor cell, which has many, many receptors on it, and the T cells, which also have receptors on it. So it's a crosstalk of PDL1, PDL2, which is programmed cell death ligand 1 and death ligand 2 receptor, and PD1 receptor that is on T cell. And when they connect with each other, they actually make the T cell defunct. So if you have a PD1 inhibitor that is inhibiting the PD1 receptor, you are then able to bring the T cell near the tumor cell and help the tumor cell be eaten up. We have immunotherapy application now in almost every organ system. Almost no organ system is spared, except for a couple of cancers that come to mind where we don't have immunotherapeutic application, like hormone-positive breast cancer, hormone-positive prostate cancer, and ovarian cancer, regular ovarian cancer. Here we don't have a role for immunotherapy. Rest everywhere, there's some or different kind of immunotherapeutic application that is already in place. So triple negative breast cancer, you have frontline treatment, first treatment for locally advanced triple negative breast cancer, chemo plus immunotherapy, pembrolizumab. Mesothelioma, pembrolizumab, or nivolumab, ipilimumab combination, all very, very in practice. Renal cell cancer, frontline treatment, we have pembrolizumab, atezolizumab, melanoma, nivolumab, ipilimumab. I'm just saying all these things so that it leaves a mark somewhere in your brain that in most malignancies, we have immunotherapy now being deployed as frontline treatment. Forget about later lines. So with or without chemotherapy, with or without targeted therapy, immunotherapy is today in frontline for many, many cancers. So here, exceptions I will just mention. Exceptions are, like I said, hormone-positive breast cancer. Pancreas cancer still does not see immunotherapy application as a general application. Still, this is immune naive. It's not an immunogenic tumor. And of course, prostate cancer, I just mentioned that. Colorectal cancer, to a large extent, except for MSI high. So there was a New York Times feature that ran around a year back, where it was a very big noise around the globe where they said 100% of response, magic for rectal cancer patients. They don't need anything now. They don't need surgery. They don't need radiation. They don't need chemotherapy. They can only be treated with immunotherapy, and it was 100% cure. What they didn't, the media really blasted this. What they didn't say was that each one of those 14 patients who had 100% response from immunotherapy were actually with a genomic marker. And the genomic marker was called microsatellite instability. So they were hyper mutated tumors. It's a syndrome. It's called Lynch syndrome. This runs in families. And these are patients that have magical response to immunotherapy. And these are mostly colorectal and uterine cancers that runs in the Lynch syndrome. So exceptions for colorectal, prostate, pancreas is when they have MSI high status. That's almost 5% of these patients will have. They respond like a magic to immunotherapy. Rest of the cancers don't belong with immunotherapy. So one of the biggest challenges that we have today is whenever we are dealing with these novel treatments, we always need to remember there is a role for multidisciplinary management. We cannot, as oncologists, know it all. A lot of the applications, so permission to be taken, one, from your colleagues. So if a patient has a history of, say, ILD, you would want to take permission from the pulmonologist, whether you can give this therapy to a patient. The patient has history of arthritis. You may be talking to the orthopod or the rheumatologist, whether you can give immunotherapy to the patient because you're going to lead to immune activation. That's the initial part. And after the therapy has started, a lot of the times monitoring the patient and managing their side effects and toxicities also really requires ACE-level multidisciplinary colleagues. And that's one of the major reasons to be talking at this meeting today, because we all work together. You have seen so many cases of immunotherapy-related complications, and this is actually one of the areas which we need your help from. So when we talk about immune-mediated toxicities, we are actually looking at a balance. So you see this balance fulcrum, and you see where the balance can tip. So you have to excite the immune system, wake it up enough to eat up the tumor cell. The T cell has to be awake enough to eat up the tumor cell. But if it wakes up too much, it will start eating up the body's own cells, and that's where it causes autoimmune reactions. So immune-mediated adverse event or immune-related IRAEs is now become a very famous acronym because it means immune-related adverse events, and these are different from the routine adverse events. And when I am talking to a patient in clinical practice or in a clinical trial, I always tell them these drugs, first of all, no cancer drug is free walk in the park. So any drug that can cut cancer can also cause heavy-duty side effects. This is my declaration to the patient. I, of course, don't want to scare them, but I also want to prepare them. So I tell them, you have to be prepared. This is serious business. Don't take it as, holy water that you can just take anywhere. And why I call it holy water, I'll explain in a second. If you take Keytruda or pembrolizumab, which is a blockbuster drug, the Keynote-001 trial that I mentioned, now we have it going up to thousands. It's a drug that is applied in almost each malignancy, and it's really a wonder drug for lung cancer, head and neck cancer. So when you look at Keytruda, 95 out of 100 patients will not have anything dramatic in terms of side effects. The drug is very well tolerated. And the poster child of this is President Jimmy Carter, who was 96 years of age when he received, for his advanced melanoma, he received Keytruda or pembrolizumab. And disease is not his problem today. He had brain metastasis. All the disease is completely gone. Old age is his problem more than cancer today. So such is the drug. So you can give it to young, old, frail, elderly, all. But one has to understand that 95% will not get anything significant, nothing worrisome. I call it holy water because it's infused over 30 minutes. It does not require a pre-medication or a post-medication. Normally, when you give any anti-cancer therapy, you give pre-medications with Avalefcorlin, Granicet, Dexa, Pan 40, whatever. All of that goes in to prepare the patient to receive carboplatin, paclitaxel, because it can give a reaction. And then post-medication also comes in. With Keytruda, pembrolizumab, nivolumab, ipilimumab, none of these drugs cause infusion reactions. In my entire career, I've only seen one person have an infusion reaction to Keytruda. Don't know whether that was related. That patient had a severe allergy to many, many things. And so when this goes over 30 minutes, you don't need to give anything. So 95 out of 100 patients will not get any major side effects, but 5 out of 100 can get any one of these that is listed here on the slide, and it can actually be very, very bad. So we have to have high index of suspicion. One, two, we always need to be oriented to this fact that this patient can develop the side effects, and it can be anything. Nothing is barred. Everything is game. Anything that a patient with immunotherapy complains, you always need to think, could it be immunotherapy? Could it be immune-mediated adverse events? And the main reason to think of that is that these drugs, once they wake up the immune system, you cannot predict. There is, of course, a list of expectations, what could be the most expected, but we have, those of us who've been in this for a long time have seen it all, would like to say, and maybe more surprises. So this is the general maculopapular rash that we see. Colitis can also be seen, hepatitis, hypophysitis, pneumonitis. And this is the timeline. So one of the things to remember, patients mostly ask me, I'm going to get the therapy today. Do I stay back in Mumbai? Or do you want to keep me in the hospital? Because, I probably will develop the toxicity within the next day. They think chemotherapy. Everybody is thinking chemotherapy, whatever memory we have. But if you really see here, the toxicity is happening much later. Why is that so? Immunotherapy doesn't work right away. It requires immune building, waking up of the T cells. They wake up by a month's time. So if you see here, 4 weeks is when things start. They wake up by a month's time, and the real impact of immunotherapy happens around 8th to 9th week of starting treatment. That's when we do the first check scan, whether the drug is working for the patient or not. And that's exactly when you see all these curves overlap. So we have to always remember that it's not immediately that you're going to see the toxicity. When do you see the maximum toxicity? When you expect the maximum response. So we measure response to therapy before the 4th cycle. These drugs are mostly given every 3 weekly. You measure response before the 4th cycle. And so that's around 8 to 9 weeks of the first dosing. That's exactly around when you also assess for complications. So if a patient is having shortness of breath and it's just been 2 days, generally, I'm not going to think immunotherapy. I'm just going to see a patient right now on 4th floor who had received immunotherapy and developed shortness of breath 3 or 4 days later. That is an exception. This patient had an IgA deficiency, has some history. I'm still wondering what may have caused immune-mediated adverse event, but that's not my routine patient. My routine patient is when I know that the patient is about to be scanned to assess for response. And right around the vicinity of that time, the patient comes in saying, I'm short of breath, I have a raspy cough. I am thinking pneumonitis. I'm always thinking pneumonitis. There was a patient, and so the black here is hypophysitis. Hypophysitis is seen mainly with ipilimumab. That's a CTLA4 antibody, one of the other receptors, not PD-1, PD-L1. So I have a patient who reported for his regular infusion and said he had been having a very bad splitting headache. And he also reported a couple of vomits in the context of the headache. And I stepped out of the room. Outside, in the hallway, I sought Dr. Chandy, and I said, how do I test endocrine-wise? What all tests do I need to send for hypophysitis? And we sent the test, and that in a few hours, we knew that this patient was having hypophysitis. So always need to be oriented, keep the antenna up, and understand whether this patient could be having the toxicity that we are expecting or trying to avoid. So I'm going to just scoot and show you one last slide where we talk about different kinds of immunotherapeutic agents. So there are vaccines. We all know that vaccines help build immune reaction in a person. Cancer vaccines are also being utilized. Their toxicity usually is on around the site. So when you inject it on a site, you see erythema, swelling around the site of injection. I talked about ipilimumab, which is a CTLA-4 antibody that usually gives colitis and it can give hypophysitis. PD-1, PD-L1 inhibitors are the major immunotherapy drugs. They're called checkpoint inhibitors, and those can give a rash. This is a Caucasian person with a rash. I'll show you a couple of images with the Indian patients with a rash. And pneumonitis, raspy cough, 4 to 6 weeks around therapy, you expect that. And the highest degree of toxicity can happen when two immunotherapy drugs are combined. And the reason why you all need to know about this is because as practitioners, we are moving into dual inhibition much more. Plus, we have around 20 clinical trials that are coming. They're in different stages of arrival at our center. They will have combination trials with PD1, PD-L1 being one type of immunotherapy, and CTLA-4, OX40, BH3, BH37, and anti-TIGIT, many different combinations of immunotherapy coming through. When you have that, the immune-mediated adverse events go up to 30%, and then you start seeing much more toxicity, grade 3-4 toxicity of these kinds than when you use single agent of nivolumab or ipilimumab or pembrolizumab. In comparison to that, when you give combination, you can just see it here, the numbers triple up. So we have to have a very high index of suspicion and manage the adverse events very well. And that's where coming to the determination of severity is most critical, because grade 1 can be managed as an outpatient. Sometimes grade 2 can also be managed as an outpatient. Grade 3, we better not manage as an outpatient. And grade 4, most importantly, managed in ICU mostly, and never re-challenge the drug. So most of the grade 4s. And how do I calculate my grade? I go to the CTCAE app and I put all the symptoms and I figure out, okay, what grade of diarrhea, what grade of shortness of breath, what grade of thrombocytopenia is this patient having? And then, of course, there are rare toxicities where we talk about the neurologic toxicities. So I've seen Guillain-Barré happening. I've seen cerebritis, optic neuritis. So like I said, nothing really is barred. All of these can truly present. I'm just going to fast forward. So IRAE management is very important. And why is that most important? Because you can control this very quickly. So I always say two things. One is think steroids. So when you have to abort an immune-mediated adverse event, you have to think steroids. And two is you have to think steroids in-house or OPD. So grade 1, grade 2, OPD management. Grade 3, admit. Don't think twice, admit the patient. IV steroids, 1 milligram per kilogram. And then slow taper. Our tapers usually happen over 4 to 6 weeks. I'm sorry, I was hoping to do it very quickly, but I think I have too many slides. I'll just 1 second. I'll just show a few images. So this is another image of a dermatitis. This is a colitis, esophagitis from Nevo-EP. This is pneumonitis, another image of pneumonitis. So very critical to remember all these. And we in India, we have to also keep in context that there could be infection and pneumonitis, and we deal with this all the time. Whenever in doubt, do the bronch. Very critical. The other things that we have to know are myocarditis. So I've seen patients who have had arrhythmia and adrenal crisis, encephalitis, myasthenic syndrome, I just mentioned. So it has to be in our differential, because if it just, we leave it out from the differential, we are done. We will never think that this is what we are managing. And that's not the best case scenario. So I just stop share for 1 second. And lastly, I want to show the algorithm for the management. I think what you all already know and manage, how you manage, is with steroids. You have, all of you have helped me manage patients in ICU, where we do this steroid management all the time. This is one slide that explains that process. So if you see here, any grade 2 or grade 3 toxicity, we are talking about 1 milligram per kilogram daily or equivalent of that. And we have to think at least a minimum of 4 weeks. Many people end up tapering the steroids much sooner. That's not the way to go. And then when we talk about grade 3 toxicity, here we are saying skin toxicity, but that stands true for anything. We have to talk about IV steroids and methylpred, 2 milligram per kilogram IV once or twice daily. You do that for 3 days, and then you come down to orals, or even keep a prolonged taper with 1 milligram per kilogram of orals, and you do it for 4 to 6 weeks. So essentially, what we have here is an index of suspicion, where we are always thinking and we are always oriented to what the patient has had. And why is it so important? Mainly because the patient could have had pneumonia. That pneumonia would need IV antibiotics. But if you only think pneumonia and you're not thinking immune-mediated adverse events, then you will never give steroids. Why do we need to give steroids? Because if there is a pneumonitis, it's not going to resolve with antibiotics. So how do we figure that out? High index of suspicion, informing your colleagues what to expect, and then the colleagues raising a red flag and thinking bronch for a patient. So think bronch, think steroids. Just thinking antibiotics for our patients is not good enough. In my previous hospital, I treated a patient who had diarrhea. The patient informed us about the diarrhea, but then kept taking antibiotics locally. We had to literally drag him by the patient. By the time the patient came here, the colitis was so florid that despite starting IV steroids, we could not save the patient. So in the last 6-7 years, over 1,000 patients treated. And when you look at the trajectory, the patients in India actually behave very similarly to international patients. The guidelines and the rules of therapy are actually quite similar to managing immune-mediated adverse events internationally. And so orienting ourselves to the side effects that can happen, timing of when the side effects can happen, and how to manage the side effects, mainly thinking steroids, is also very critical. And the reason why is it critical is because it can be life-saving when we get to the steroids in good time. So with that, I end my presentation, and I will be happy to participate in any question and answers that we may have, and also discuss cases. And thank you for having me. Hopefully, I've given a brief speed tour.
I think we would have loved to listen to more in detail, but I think we will gradually learn more from you, because the diverse field of immunotherapy, and leave aside remembering their overall applications and others, at times it is difficult for us to pronounce it. The maps are so difficult in the nomenclature. on that. I always quoted that. So I think let's listen if there are any questions. Otherwise, anyone, any questions? Or I do have certain questions to ask you, madam, to take
Please.
it forward. Okay. So I think precision medicine you started with. We will definitely have more. We'll invite you more for the precision medicines and learn about all that also you do. But if you can please kindly say that with the process of what you do on predictive and prognostic enrichment
Sure.
in the translation.
Excellent, excellent. So when we talk about predictive and prognostic enrichment, and just taking a moment here to explain what Dr. Arindam has asked, essentially we are looking at what marker can prognosticate whether this disease is going to behave this way or that way. And then predictive is what marker can predict how the disease is going to behave with the application of a therapy. So I'm going to give you an example. When we have early stage breast cancer, someone who has a 2 centimeter hormone positive breast cancer, does not have any lymph node metastasis, that's a case which we would routinely think as being very, very dormant, easygoing, does not need chemotherapy, but it could actually be a strong biology and a mischief maker. So I always say the difference between a gems and a masala matar. So gems is when you eat, you're going to find it very sweet, even a chota bachchu can have it. And when you have masala matar, if you give it to a 3-year-old, he's going to start crying. That's what biology is. When you have a small lesion, that lesion can behave in a very dormant way, or that lesion can come back with metastatic disease. I just saw a very high profile sensitive case where we are contemplating that the prostate cancer metastasized, and you look at the prostate cancer that was treated 3 years ago, it was a 1 centimeter by 0.65 centimeter tumor. So if that metastasized into a small cell disease that has gone all retroperitoneal, then that is a masala matar. Why do I bring this biology context? Because of the question that Dr. Arindam asked. When we have a small breast cancer that is hormone positive, we actually don't know whether it is going to be aggressive or is it going to be a dormant, slow growing thing. We take it out, we treat it. Whether the patient is going to then benefit from chemotherapy is another question. So we do a test called Oncotype DX analysis. Oncotype DX analysis is a 21 gene analysis that now has 10-year data to follow through. So if someone has low score in Oncotype DX, they have a GEMS. They don't have a masala matar. That disease is going to have a good prognosis. Slow growing disease will not come back and will not benefit from getting any chemotherapy. So no benefit, no survival advantage by giving chemotherapy to a patient like that. You actually just give them hormone therapy. Similar patient with an Oncotype DX score of 57, 73, that's a very high number, the cutoff being 17. And in such a patient, we know, one, they have to have very strict, strong surveillance. So that's a patient that needs very, very close trajectory of follow-up. And two, that patient is going to benefit from giving chemotherapy because chemotherapy helps fast dividing cells. That's a highly aggressive disease. Whatever is minimal residual microscopic disease in the body is going to have a high chance of elimination with chemotherapy. So that's predictive. Prognostic is the fact that this is the biomarker and this patient is going to do well irrespective of what therapy you give them. And predictive is when we are determining the therapy with the help of the biomarker analysis. And so most of the biomarkers that we utilize in medical oncology are actually, we are looking for predictive mostly because we want to figure out whether the therapy will work, this therapy will work, that therapy will work. But then there are also prognostic markers that inform the field, where just by looking at that prognostic marker, you're able to tell this patient is going to have a slow course or this patient is going to have a very fast, aggressive course. So I hope
The analogy in critical care, madam, why
Yes.
I asked, because our people will also like to have to listen to this one, is that we have very heavily borrowed from your concept, and we have applied this in sepsis, in AKI, in ARDS and others, where we are trying to find out subphenotype based on not only on clinical features but also on certain biomarkers or even genotype, your gene types related,
Mhm,
so
mhm.
that we can select proper patient who will benefit very positively on a certain subset of treatment process. So that
Right.
means that we can actually, that you said, that we can actually pre-select patients which will very positively react to a certain subset of treatment itself. So this is, I think, a future on that part, which Madam said. Okay, you said IgA level. So we have seen a lot of our physicians do IgA level before an immunoglobulin. Do you need to do an IgA level for this immunotherapy?
So actually, no, that the level modulation is mainly research related. A lot of our literature mentions the measuring, but in clinical practice, there is no place, there are no guidelines helping us understand what would be the implication if we were to measure. So mostly these are incorporated in research labs, especially to understand the immune mediated adverse events. And there is a colleague of mine who's dedicated his life to immune mediated adverse event monitoring and building AI tools to develop additional strategies to treat it or capture it ahead of time. They do that monitoring. I actually am privy to their lab work, and so I'm aware that they do the monitoring. We don't in routine clinical practice.
And we don't need to do it, right?
We don't
It's
need
not
to do
root
it.
and rational.
Practice
Okay.
doesn't have.
So you answered my third question, which I was thinking, that the combo therapy, combo immune therapy, you said is already being there, because it's a natural progression of our development, that we will try to attack as many as your receptors to modify the disease process. So I'm aware of that there are combo therapy, and you already well explained that more the combinations or more the immune therapies, more would be the different side effects that we can expect, right? And the severe most side effects will land up in the ICU, grade 3 and grade 4. So that's the idea of having interaction with a person like Madam Sevanti Madam, that we should know about that what we are dealing why this drug has been given, what is the background of the patient and the disease process itself, and what are the myriads of immune related adverse effects the patient can present with, right? So that we are much better prepared in this era of immune therapy with the disease process. Madam, you said about an CTCA app. I'm a little intrigued. So this is
So
all.
the CTCAE app we had to download for all our clinical trial management. And it's the version 4 and 5 that has now come through. And we actually really need to take its help to grade all our toxicities for the trials. So,
Okay. So is it clinically also important, or it is just on the for the sake of the trial, or just to
good question.
report your adverse events?
I actually take help from it all the time because I feel, the entire algorithm is based on grading. And me being a clinical trial person, my memory also is completely in sync with that. So grade 2 होगा तो ये करूंगी, grade 1 होगा तो ये करूंगी. So grade कौन सा है? Especially if I have a patient, and I think I showed a case where you have a patient who has the extensor surface of all extremities involved. So if you calculate, it's like the burn calculation. So when you
Right, madam.
calculate from the imaging, what grade will it bring you to? So when you have something that objective that you can calculate the grade, asking for a solution becomes so much more easier. So that's
Fair
when
enough.
looking at the grade with the help of CTCAE app helps.
And I was intrigued that hypopituitarism or hypophysitis, you said that. What did David said to you? That is there any clear-cut basic investigations that we can send?
So we did ACTH, we did we had
TSH, yeah.
TSH, ACTH, we did FSH, LH levels.
Gonadotropins also. So all the three lines:
All the-
thyroid, steroids, and gonadotropins.
Correct. And
This,
we
does it also affect the posterior part also? The posterior pituitary secretions
I
mostly.
don't think posterior was
So it's
tested.
mostly the anterior pituitary and all the three lines that need to be tested.
Exactly.
Madam, is there any antidote sort of here? Because we always we
So
were
that-
like a quick fix.
That's such a that's the word actually. If I leave you with one word today, the antidote is steroid.
Okay, steroid is a
Steroid, yes. So what we need to do, two things we need to do when we are putting anyone on immunotherapy: keep communication lines open. So the patient needs to tell us. We used to, when we ran clinical trials at the previous institution, we used to give our previous, our personal numbers. We would tell them, if you're going to the village, you let us know. If you're having diarrhea, you let us know, because nobody is thinking steroid. Diarrhea hai, so people will give Ciplox. Diarrhea hai, so someone will give, O2. And we'll keep giving that for weeks together, versus that the patient is on Nivo-Ipi, patient has 30% chance of colitis, 30%. So if the patient has diarrhea, you need to think antidote, and that antidote is steroid. And so that's a brilliant word, orientation to immune-mediated adverse events and steroids, very critical. Of course, we need to give it under the cover of antibiotics. And of course, you need to involve a multidisciplinary colleague who will do a quick colonoscopy, prove that this is what they're dealing with. If this procedure is getting delayed, you cover with antibiotics and you give the steroid alongside.
At times also, as you are repeatedly reminding us that we have to be worried about the infection part. So at times there are, yes, Dr. Pandit is back actually. So at times there are dilemma that whether there is an infection also. So do we need to, or is there a way for a tissue diagnosis or a
Yes.
more invasive diagnosis that
Yes.
IRA is happening?
So always, this is our teaching, this is our learning, that they say never treat blind. So if you have a patient who's coming in with shortness of breath and ground glassing on both sides, you have to think PCP, and you have to think other causes as well as pneumonitis. So we had a patient on pembrolizumab here, MSI high patient on pembrolizumab. We brought him in. He had ground glassing, was thought to be pneumonitis. We quickly brought him. He was treated for PCP within a day, or within 48 hours, really clear. And oxygen requirements went down. So in this case, the patient had PCP. In another case, which I said, the lady developed within 4 days extreme shortness of breath. This patient just responded magically to steroids because of immune-mediated pneumonitis. So diagnosis was done with help of bronchoscopy.
Pandit sir, any questions, please? You have to unmute.
Sorry, we had our skin specialist madam come in for the other lady, so I had to go into the ICU.
No problem. No worries. This was
I
mainly.
think this is a fantastic discussion, and I heard the discussion about antidote being the steroid. That is really very important, that we rarely come across steroid as a first choice of therapy for these kind of things. So Dr. Sevanti, are we actually starting these trials with us right now? Is there any trial going on right now?
So not going on right now, but we have actually been accepted as a site for multiple of these trials, and many of these trials are actually going to be with dual immunotherapy. So we really will need to come up to speed with multidisciplinary management, and I'm slowly meeting everyone. So Monday, I'm also meeting the pulmonary team to because we deal with this all the time. We don't know whether this is infection. Patient has now been on it for 8 weeks. You know that pneumonitis could be happening as well. But is this pneumonia? Is this infection? And the dose is pending. The patient is in the daycare. And whether you give the next immunotherapy dose or not, and it's a matter of bronchoscopy. So our colleagues need to know, we need to know, and the entire, I think, armamentarium needs to be created around it.
Yeah. One more question.
Yes,
We
please.
talk about signature gene in sepsis. We talk about the signature gene in oncology as well now. What is it that is now going to be the niche? Are we still going to have these toxic medicines, or it's going to be everything immunotherapy now? Are we going to get rid of the oncology drugs, the so-called chemotherapy drugs, and target only immunology as a primary? Is this the prime? Has this therapy become prime time that it is the first line therapy?
So
Or is
it
it
has
second line
become
therapy?
prime time. You are absolutely right that it has become the prime time. It has become the gold standard. It's become the blockbuster, all the mega words that I can use. But the good old chemotherapy cannot be written off, because very recently we were presenting something to a very big team in India, a research team, and the pie chart showed how the genomics was really exploding, and it was taking care of 40% of the cancers and was the answer for these 40%, and the rest, the 60%, was all black. So immediately I said, that I didn't want to make things bad for them, so I didn't point it out there, but the Harvard team was presenting. But I was like, dude, the 60% that is there, the elephant in the room, is getting treated with chemotherapy. So we need to better our methods of figuring out which chemo is working and which is not. And that is why I'm a huge fan of doing chemosensitivity analysis, which is a taboo in the rest of the world. But I feel the way the urine sensitivity has been mastered is the way chemosensitivity needs to be mastered, and there has to be a lot of work done in that area. There are people across the globe working on it, but it is a less utilized method to really inform which chemotherapy to give to a patient.
This next question from me is just for my information, and everybody, I'm sure everybody else would also like to know. Are there labs which actually just specialize into this in Mumbai or in India, which can have a turnaround time which is very short, maybe a few days or few weeks, and give you an answer, or we have to still send samples abroad?
No, so I do partner with labs who are very, very astute, who are internationally accredited, and who are very quick. So we at Reliance are also trying to build it, but we are in very, very initial stages of that development. However, outside, within, I would say Maharashtra, we have certain labs that are very good. They are really emerged at a world level. So I partner with them, and the turnaround is usually within a week. Very, very complicated tests. The turnaround is 4 weeks for general testing, especially if you were to send it abroad. But there are labs within India, within Maharashtra, that will give you a turnaround of a week.
That's not bad. That's pretty good. That's reassuring to know.
Yes.
We have a home turf where we can actually request this test, because obviously
competition
when
is
we request it at home,
exploding.
the cost comes down significantly. Yeah.
Right. Yes.
Arinda, back to you, my friend.
Thank you. Anyone else? Any questions? Tushar, Shalaka, Advait, I can see many of them. Dheeraj, you are there. Any questions from your end? Okay.
So I'll just say a couple of things before you end. So thank you so much. I have been majorly supported by the ICU team and really grateful. I did not want to miss the opportunity to come and say thanks. And so I thought this is the best chance. And
now we will have this, madam. Don't thank us too much. we are going to come back.
Game anytime.
We are going to come back and we would learn, because it's, if you see now, I think Panditji will agree more with me. The percentage of oncology patient in ICU, right, and then with the almost 22 oncologists with also and the oncosurgeons not counting, right? We are going to have so many patients, and now oncology is not the end of the road. Oncology patients coming to the ICU. I think it's the a
It's
little
progress.
stormy beginning, but beginning of their life.
Correct.
So it would be more and more patient, and we need to learn for our good or our sake.
Thank
So we
you.
will come back to you, madam. So
Thank
you
And it was a
it
pleasure.
deserve the thankfulness. Yeah, thank you.
Thank you.
And despite you are having a tough time, you have been awake all the night. We really thank you from our core.
Pleasure.
So
Thank you very much, Dr. Limai. Thank you.
Thank you.
so we'll meet soon on critical care oncology.